First of all, I'm James Bourgeois. I'm Chair of Psychiatry at Baylor Scott & White Health. We're a large system in north central Texas. My hospital is Temple Memorial Hospital north of Austin. We also have Baylor University Medical Center in Dallas. Dallas and Austin are 200 miles apart. Our catchment area is also 200 miles east to west, within which we have a network of 50 mostly community hospitals and numerous primary care clinics. But we're the only academic psychiatry department for the entire system. So the need, of course, is to provide telepsychiatry consultation support to the 50 mostly small hospitals. So our current initiative is to hire a cohort of 8 experienced consult telepsychiatrists to work in my department, but to actually be deployed throughout the whole system through a complex scheduling matrix and so forth. The hope is that we can provide timely consultative care by members of my department with good quality control and good relationships with the local hospitals. We're early in recruitment, and we should be starting actual operations within the next month or so. Well, during my prior time at University of California, I actually ran 3 telemedicine programs there. Those were relatively smaller, and those were outpatient focused, but I became comfortable with the idea of integrating telepsychiatry as a way to do consultation psychiatry. Because of our large geographical area, places such as Texas really frankly ought to be masters of telepsychiatry because there's no other way to get the service properly disseminated. Fortunately, the Baylor Scott & White system has made a large institutional commitment to telemedicine for all departments. There's a developmental office run by an administrator. Their charge is to look for opportunities for telemedicine in every possible place. So we already do telemedicine primary care advice for relatively simple problems. We have a telestroke service where neurology does the same sort of service for patients presenting with stroke at distant hospitals. We're patterning it off of that. Our system is a large integrated system. We have a common EMR system. So access to all the relevant data is actually pretty intuitive. Well, the technology has accelerated enormously just in the 15 or so years I've been doing this. Never anymore do you worry about signal integrity, auditory integrity, security of the lines. It's not even expensive. So this is technically the time to be doing this, and it's, of course, quite easily integrated into modern EMR systems, where you can even record sessions should you have a need to do that. So the advantage to us is it provides specialty care to the patient where they need it in a very focal, timely sort of way without problems with transport and access and things like this. Well, the emergency rooms much appreciate the help because if they don't have some service like this, they either need to rely on some other means, local practitioners who are few and far between in many of these communities, or they have to send the patient for an outpatient encounter, and that's logistically difficult. So as a way to get the product out to where the patients are and what they needed, I think this is the logical medium to do it. The whole system will ultimately be on the same EHR system. Currently, most of the places are on the same EHR system. We should be fully operational by spring, summer of 2020, based on our current projections. First of all, that you have a dedicated consultant that is the person you know over time rather than using other means to use contractors and other sources. Because of that, you get to know each other's practice patterns, what to look for, how to communicate workups and things of that sort. Another advantage is the emergency doctors may even call for advice even without a patient being there, just because they know they have a source of a consultant for another question. The financial administrative part is under evolution. Until somewhat recently, there were certain regulatory problems. Some places you couldn't charge for telemedicine services for certain kinds of activities. I won't get into the details of that. there also has been problems with insurers being willing to pay for telemedicine services. Fortunately, as policymakers are awakening to the fact that this is a very good medium, those barriers are getting less than they used to be. And I don't see that as a major operational problem hereafter.
Okay.
That used to be thought. I don't think really that's very valid anymore. Rarely do patients fail to engage with the medium. I can never once remember an example where, for example, the patient was paranoid about the hardware, that this was, part of the delusional system. Folks wonder about that. I just don't think that happens. By far and away the more common experience is that these rural hospitals and these rural patients are very grateful to have access to specialty care and are frankly kind of used to technology as a way to get there. So I think it just meets expectations in a really very reasonable, arguably patient-friendly way. In the sense that we will be able to provide consultative services for our whole system, which heretofore we only been able to do in person, yes. We also, in a parallel way, are doing some primary care clinic support by telemedicine, by embedded psychiatrists who stay at our hospital, but then provide clinic follow-up in primary care using the same telemedicine medium. Well, I would globally encourage them to look at it. This is by no means restricted to places with geographical distance, though it's most appropriate for them. Even within a single city, it may be valuable. At UCSF, for example, we used telemedicine to support one of our small hospitals that was within the city, but because of travel logistics was not easy to get to. And this has been done in other places as well. It's generally been very acceptable and a very good alternative to other staffing problems. Well, many of our members are already doing this to various degrees. Some places have been doing this for quite some time. I think a general stance on technology adoption as a policy of where the board needs to go to guide the organization from here would be reasonable. It shouldn't be seen as an innovation, but more, if you will, a consolidation and enhancement of some things that are already being done. Where we develop a common resource document or a how to this, how to that kind of document. I suppose some places might welcome that. I would be very interested in what are the expansion possibilities for telemedicine in other nations. I don't really know, other than Canada, where they've adopted it quite well. I don't know what's the status of in other places.